Just to wake you guys up, can somebody read this for me, please? I need somebody who hasn't read something yet.
I can read.
Thank you.
Excuse me.
No, you can't if I hide it. I'm sorry.
Morally, you have no right to demand medical care of me. Your necessity does not change the basic math. Medical care is a service and a good provided by a third party. Medical care is a commodity, and treating it otherwise is foolhardy. And whereas government sponsored medical care requires a top down approach that violates individual liberties, generates overdemand, and quashes supply, markets prize individual liberties, reduce demand, you generally demand less of what you must pay for, and heighten supply through profit incentive. Uh, Ben Shapiro, editor in
Yeah.
chief of the Daily Wire.
Thank you. And this has been the underlying river and current that's driven medical care in the past 20 to 30 years. Somebody want to read this? Another volunteer? Someone who hasn't read yet?
I can read it.
Thank you.
Despite spending far more per capita on healthcare than any other country, US has some of the poorest health indicators in the industrialized world. It is the only industrialized nation to deny its citizens universal access to medical services. This record can be largely attributed to the notion that healthcare is simply one commodity among others, a privilege for those who can afford it rather than a fundamental human right for all. It is no surprise that healthcare costs continue to spiral out of control for ordinary Americans, even as the health industry accumulates record breaking profits. Only a new approach, recognizing the right of every American to adequate healthcare, can address the magnitude of the current crisis. Sarah
Thank
Zaidi? Don't know if I pronounced that right.
Super. And that's 20 years ago. So, as physicians, as clinicians, as folks who are health professionals taking care of patients, the bottom section might resonate a lot more than a Wall Street executive on the top section. And again, your mission as you go through your careers is to help provide care to your patients. But unfortunately, it's going to require the public understanding that perspective that is mentioned. So here we are. Um, so I'm going to plunge into history. Thank you for that preface and how market fundamentalism has run through the past 30, really 40 years. You remember that we had the deregulation of the 1980s. And we had some needs that you just heard about perhaps this morning with Medicare. So we have two populations of constituents. Um, the elderly tend to vote, and that constituent was clamoring for updating of Medicare. The original benefits did not have coverage, as you know, for these services. Premiums were increasingly expensive. Longevity had changed from age 67 to 79 or 80. Medical advances, rising drug costs, etc. So, in an age of privatization, Congress elected to accommodate industry rather than expand traditional Medicare. And with the Medicare Modernization Act of 2003, the drug plan Part D was introduced, and Medicare Advantage took off due to some increased incentives provided to insurers, which also allowed increased advertising. So we're basically, and you may have seen this slide from yesterday, it's an age of the middlemen. This Part D plan was, had you heard much about Part D so far? It's the drug plan. So, okay, so I'll briefly, maybe I won't even, if you've heard a lot about it, I'm going to skip through this. But this is just temporarily what was going on in 2003. We were talking about some other issues going on. Bottom line, it was basically a handout to the industry, the insurance company industry, and the pharmacy benefit managers who were separate initially, but then became integrated into Medicare Advantage plans. The bill was written such that it could not negotiate with drug makers. Medicare could not negotiate directly with drug makers. It had to be between the pharmacy benefit managers, and those were secret legislation, secret negotiations with which are not transparent. Anybody know who this is? Have you already seen this? You guys know who this is? Any guesses? No, that's Alex Azar. helped. He was a lobbyist for the pharmaceutical industry and a former CEO of Lilly Corporation. And he wrote the Part D legislation as part of Medicare Part D. Actually, he came on to be the first Secretary of Health and Human Services under Trump. That would be 13 years later in 2016. Man, there's such discrepancies in who this guy chooses as Health and Human Services. Here's this man's from the business sector who'd written Part D, and now we have RFK Jr. I can't fathom it. But here we are. So anyhow, he wrote the legislation back then. All right, so enough about Medicare. Let's talk about the rest of America, which are the non-elderly. And so we touched on this slide last time I saw you guys. There was a progressive loss of legacy insurers, economy changed, gig insurance changed, recessions, of course, as naturally take place, but ultimately, due to lack of affordable insurance, 40 million Americans who are non-elderly, 18% of the non-elderly, went without health insurance and were vulnerable and often encountered medical bankruptcy. Part of the reason that they could not afford it was an employee-sponsored insurance premiums were growing 3% per year. It had increased 22% since 2018 to 2023. And profitability was assured, but the ability to pay for it was not. So this is the annual premiums for a single person in 1999, which goes up from $2,000 to $8,000. For a family, it goes up from $6,000 to $24,000. This is way beyond inflation. And it is encroaching on people's ability to actually spend money on other items, including housing and other issues. That growth in healthcare spending over these 20 years actually was getting close to 30%. So something had to be done, hence the Accountable Care Act. Again, the origins of the Accountable Care Act were from the private sector, actually, and from, I may have mentioned this, from the Heritage Foundation, which is a lot of your friends and parents do not know this. But this was the brainchild of the Heritage Foundation. In 1989, some thinkers there in this conservative think tank came up with a concept for universal coverage via an individual mandate. Everybody had to be in to put in their skin in to cover the risk pool to help with community rating of insurance. Refundable tax credits were pegged to income and health status, and there would be a minimum benefit package. And this was actually unveiled in Massachusetts, a state just south of where I live, by Romney. And essentially, this was a plan that was expanded into the ACA. Now, one thing you might not know is the ACA was actually initially written to include a public option. How many of you know that? So you guys may or may not have been cogent of what was going on in politics in the election before the last, back in 2020. Did you hear, has the word public option resonate a little bit? Anybody heard that before? No. Okay. Well, so that being the case, the public option refers to my inability to deal with technical matters. No, it doesn't. Help me, God Almighty! I could blame it on sleep deprivation and jet lag, but that's getting old. Anyhow, so the public option is offering either Medicare or Medicaid, that is government sponsored coverage to those who are otherwise not usually eligible, and it would compete with private insurance. This was passed by the House in 2009 as part of the original Affordable Care Act. What happened is it got eliminated when it went to the Senate by Max Baucus. who was on the finance committee. And there, but in any case, the public option would allow middle income people, not the poor, working age adults, to choose either a plan like Medicare or Medicaid, the details to be further determined. This is the former president of Physicians for a National Health Program standing up uninvited at the open public hearings for Max Baucus's Democratic Finance Committee when they were hearing the Affordable Care Act. Any options of this nature were basically not allowed at the table. And it was excluded in advance. They felt it would not pass. They also had perhaps other ideological reasons to not include it. But in a tight conference where the Democrats held a slim lead, it was not to be. And actually, she was taken out by police. There were about 4 or 5 other Physicians for National Health Program advocates who were removed from police because they did not have a seat at the table. Again, it sounds like you may not have been plunged into politics in 2020, but 10 years later, all the Democratic candidates before Biden got elected offered a public option. It was quite striking. Um, why didn't it get incorporated? Why wasn't it considered again? Do you guys remember the policy trap? Whereas if you have a lot of satisfied voters with their current insurance, it wouldn't help move the needle. So basically, it wasn't just the process of buying off the insurance industry, but it was having enough Americans who are adequately satisfied with their health insurance to not have public option incorporated into the plan. So the Affordable Care Act ultimately did pass in a Democratic Congress. And rather than extending Medicare to those less than 65, it used private markets. So the Affordable Care Act would basically, its primary act was to expand Medicaid from 100% up to 138% of federal poverty level. So that's a lot of people. It also extended something called a marketplace or exchange of of a number of 2 or 3 private insurers on a state-by-state basis who would sell and manage insurance to those who were above 138% as well of federal poverty level. So they were low income, but not enough that they were Medicaid eligible, but not poor enough to be eligible. Those companies who are offering their health insurance would get federal subsidies to offer a lower price to the enrollees. And the subsidies were essentially tax credits, quote unquote, that were given to those people, but not paid to those people. They were paid directly to the private insurance plans to lower their premiums. Kind of wacky. That's how it got written. Welcome to some cockeyed systems. So basically, if you have federal poverty levels income levels between 100 and 400% of federal poverty levels, you would be eligible for having a lower premium due to subsidies. A third element of the Affordable Care Act was that healthy young people had to enroll. There were penalties, modest, but real penalties, financial penalties, if you did not enroll. And that was, again, the intent to have a large pool of healthy people who would pay for the small percentage of people who had high medical costs. There was also an employee mandate, and there were 10 essential benefits that had to be provided. Is this stuff you've already gone over, or is this new? Can't hear anybody. Anybody want to? Have you already? Yeah,
I think it's mainly new.
good. As far as I understand, it should be. So this is what we are living into today. The Affordable Care Act did pass in 2010. And again, other features. Remember, we were talking a lot about folks having HMOs, having hypertension, their blood pressure medicines were not covered, having cancer, the screening for their recurrence was not covered. Pre-existing conditions was a major issue with for-profit HMOs in the 90s and 2000s that eliminated insurance companies from being able to deny coverage for pre-existing conditions. There's also no limit on annual maximal coverage amounts. How many of you are covered under the ACA? Do you guys know? Yeah, so a lot of young people are actually still covered under the ACA. Um, there are incentives. Again, a lot of folks are not aware of this. There are numerous hospital safety incentives to try to prevent readmission for like infected joints. If a hospital previously, if you did an operation, replaced a knee, and that joint got infected, you just readmitted the patient and got paid for the next admission. Yes, we talked about drug-related, diagnosis-related groups. You might have a package of reimbursement for septic knee. But if you guys were responsible for that knee getting infected, you could still pay for it independently for that next hospitalization. These incentives said, no, we're not going to pay you for it. If you have a complication that's avoidable, you're going to eat it. So hospitals made major efforts to clean up their act to help prevent any complications as they were able to. There's a variety of other incentives for coordinating care and helping to have a handoff of the baton between the hospital care and the outpatient settings. A variety of other issues that you're probably not aware of. Um, the ACA limited profits. The old, that is age 64, couldn't be charged more than a 24-year-old it couldn't be charged more than 3 times that of a younger person. And again, these essential benefits, outpatient services, pregnancy, maternity, hospitalization, prescription drugs, mental health, preventative, a very important issue, colonoscopies and preventative services would be covered as well. Well, this was not responded to well. This is sort of an astroturf movement. So the Koch brothers, I'm not sure if you've heard of them. Again, they're a private, wealthy, right-wing group. Actually, they're no longer right-wing by today's standards, but in the 2000 noughts and like, they sponsored folks reacting to these insurance restrictions and regulations, essentially. And I love this was not uncommon. There's a sign there, keep government out of my Medicare. I mean, this is a level of like ignorance and that we see to today's date. People still don't quite get it. But that was part of the protest. It was there were Tea Party meetings across the country. Representatives were yelled at their town hall meetings. There was a lot of reaction. In 2012, Mitt Romney, a former governor Republican governor of Massachusetts, was running against the reelection of Obama. And I love this cartoon because basically Romney ran earlier on the success they had in covering people's health care in Massachusetts. But here he's saying to Obama, your kid, which is just like my kid, is ugly. That was the nature of the world at the time. Um, did the Affordable Care Act work? Yes. Essentially, the estimates that were made about how many people would gain insurance on it actually came to pass. Those projections were correct. Those without health insurance dropped from 50 million in 2013 to 28 million in 2016. Bankruptcy filings for medical bankruptcy dropped coincident with that. It did have some benefit. Here is sort of a timeline of this events. And again, it depended on Medicaid being expanded in states. What we'll see is that you see that little bump that's occurring. It dropped down to 11 million uninsured and then started to climb back up. All of this was due to impediments placed on ACA with passing years. But here again is an example of the majority of its actions in getting more people covered was via Medicaid, not so much via the marketplaces. So this is Medicaid enrollment between 2013 and 2019. So what were these measures to try to hobble the ACA? As I mentioned, initially, states were required to expand into their Medicaid. But 26 states sued, typically with conservative attorney generals, and went to the Supreme Court, and they said, yes, it is unconstitutional and coercive to have this federal legislation apply to all states for a program called Medicaid, which is state administered. So Medicaid expansion became voluntary throughout the United States based on what state you live in. Here's an example of, and by the way, there's been an incremental movement towards more and more states expanding Medicaid via, and adopting the ACA. As of 2023, there were just these states in gray that no longer were still not accepting expansion of Medicaid. Mississippi agreed to expand Medicaid, but only if a work requirement waiver were allowed to be the case. We're going to see that in the months and years to come, that new draconian Medicaid requirements are going to be kicked in to what states do for providing coverage for the lower income Americans. But the trend was positive. More and more states did expend it, even though it was voluntary. The other thing that hurt the ACA was that individual mandate to maintain community rating premium prices was repealed in 2017. The mandate for businesses was continued, but that also helped to increase the price of your, platinum, silver, and bronze programs that you might get in the marketplace. The way that it was funded took some hits. And then subsidies to insurers for low-income earners was repealed, again, raising the unaffordability in the marketplaces. And lastly, under Trump's first administration, they allowed alternatives that did not offer those minimum benefits, preventative care, emergency room services, etc. So that was happening and precedes the world that we live in currently as the most recent major health reform that occurred. What was happening in the insurance markets, of course, we've touched on in the past, is climbing deductibles. So this is for folks who are getting their insurance through their employer, not through the Affordable Care Act, not through a marketplace, not through Medicaid. But for folks now, the majority of Americans, by the way, who are receiving their health care still through their employer, it was increasingly becoming unaffordable due to rising deductibles. Premiums were also going up, but deductibles were going up even higher. And here, 256% compared to how much was being paid, 58% in terms of medical loss by the insurer, in terms of how much is it really costing the insurer to put out money towards health care. It's dramatically higher. Co-payments were also going up, co-insurance was going up, and premiums were going up. Here's the increase in family premiums. Again, this is typically for folks who have employee-sponsored insurance. You could see how it compares to earnings and overall inflation. Here's an example of what's going up with deductibles. So this was a striking new measure by the insurance industry. By the way, these high deductible plans were also linked with something called health savings accounts. I'm not sure if you guys may not know much about this, but for higher income earners, many physicians, for instance, employed by a large employer, would have something called a health savings account. What the heck is that? Well, it's a it's a way to lower your taxes by if you're having to spend money on on something that your deductible is not covering yet, you could you could take money away and out of a pool of money set aside as a health savings account. Your employer, this is a little complicated, but your employer would basically take pre-tax dollars. So they're paying you $100,000 a year. They'll put $5,000 a year of your salary into a health savings account that you don't have to pay the IRS for. Those $5,000 you could use to pay for services that the deductibles were not yet covering, for instance. What? How did that come to pass? Where did that come from? Well, that came from the banks. They are the ones who administer health savings accounts. We have a wacky system that is totally dedicated to non-health goals. So the health savings accounts actually were instrumental in creating these high deductible plans. All these intricate processes are going on that the public is not really aware of. So anyhow, do deductibles work to lessen healthcare costs for insurers? Yes. What was their supposed theory? Well, in a competitive free market, those high deductibles would lead patients to seek the services at the highest quality and lowest cost. But prices are not transparent, as we talked about briefly the other day. They could vary by tenfold across a community and higher across states. They're not competitive, not due to reforms, just due to the nature of healthcare and markets. And folks who do have high deductibles can't really understand what they need and what they don't need, and don't have crystal balls to know if they need that colonoscopy, if they're going to get or some other procedure, see the dermatologist because of a changing skin lesion. So they forego or delay all care, not just the care that is essential. They work to lower healthcare costs, but do little to improve care. And ultimately, they do little to lower our nation's healthcare costs because problems arise because people don't get the care they need and become more expensive as a consequence. I'm throwing a lot of stuff at you. Is any of this computing or is this inscrutable? Am I, does it, any of this sort of, yeah? Okay. Let me know if you have questions. I'm jumping through the 20s. So we have Trump care, round one. By the way, that's a sign from the National Health Service, universal health care. Keep your hands off National Health Service, Mr. Trump. That was back in 2017 and 18. He was trying to negotiate bringing American-style health care to England, which he has done in part, by the way. Well, in Trump's first administration, there was this major goal, which continues to this day, to repeal the ACA. How many of you are keeping tabs of politics, what's going on currently, and the insanity in the world we live in? So there's something called budget reconciliation. You don't have to put a bill before the entire Senate. If you just have like three more senators on one party than another, you could try to put in national policy when you put in a budget. And that avoids a filibuster and avoids the other party from shooting down your bill. Well, they did this back, and they're practicing. Maybe they'll get it right this time. That's what's going on currently in Congress. But back in 2017, there was this Graham-Cassidy Reconciliation Act that would basically repeal the ACA, and to keep it short. It was shot down at the last moment by a fellow by the name of McCain. And John McCain, his vote was uncertain until he got onto the Senate floor. He put his hand up like this and said, I don't want this bill to pass. And it upset the apple cart. And that allowed the ACA to remain to this date. What was instituted during that administration, however, as I mentioned, he allowed these skinny plans, essentially junk insurance, cheap for the patient, which is great, but they wouldn't cover anything to prevent health catastrophes and might or might not even kick in when you had catastrophic healthcare costs. Um, and It also allowed employers to deny coverage for birth control. There was what we call navigators to help folks through the complex ACA legislation. They ended that. They ended the advertisement for the Affordable Care Act insurances. They allowed states to implement things such as work requirements or other punitive Medicaid burdens to jump through. Again, this is not surprising in the world we're living in. They threatened the deportation of immigrants if anybody in their family used Medicaid or nutrition services. Again, we mentioned the allowance other burdens to receive Medicaid. And then something called COVID happened, as you are all familiar. And that basically, and I will say, and we may have a separate talk on COVID. Some very positive, important things happened during COVID. There was government industry collaboration around COVID vaccines, which ultimately have saved many lives. That was the Operation Warp Speed, made rapid development of mRNA vaccines and other vaccines, which made a dramatic change. So that was a success story of collaboration between government, basic science, and industry. One can argue that the pharmaceutical industry made a bundle, but initially the immunizations were affordable and widely available. It was a success story. Well, what was going on just around this time? So remember, COVID happened, really hit New York and hit the world February, March of 2020. Democratic primaries were happening around this time too. Um, and we mentioned this public option. Again, the word is familiar to people who were voting at that time or actively involved in politics because so many people were proposing such theories. You've heard of Bernie Sanders, you may have heard of Elizabeth Warren. They certainly have ongoing efforts to create public option, that is, get the younger population covered under national programs that would be actually more affordable than what they're for the nation and our GDP. But so did Murphy and a thousand other candidates running for office. Um, uh, Biden, of course, was elected, and one of the first acts that Biden did was this Families First Coronavirus Response Act, which made sure that if you had Medicaid and or you had an employee-sponsored insurance, if you lost your job due to the massive layoffs that happened during COVID, you'd still have to receive coverage or go on to Medicaid. It assured that Americans would not lose their existing coverage, and it was successful. Again, people don't remember this. We have short memories. But if you look at the percentage of the unemployed, a percentage of the uninsured, remember it was up at 18, almost 19%, dropped dramatically after the ACA. So staying down here, started to actually climb a little bit already, but then it was going to shoot sky high with the loss of people's coverage. But the Family First Corona Act enabled people to still have their coverage during a time of COVID. Um, Another thing, by the way, I don't think we've talked about pharmaceuticals yet. But just as there are outrage in the public for aspects of health insurance, there are aspects of outrage for the pharmaceutical industry and the rise, and insulin is one such example. So insulin, when it was first released, so these are humanized insulins. They ain't new. In fact, they came out even before 2009. But this is regarding Novolog, Lantus, Humalog. These are both short and long-acting human insulins. When they were first released, they were costing about $80 for a vial. A relentless rise in cost, not because the manufacturing became more difficult, it didn't, became simpler. You could see how it climbed over the decades, such that it was, 3 times, 4 times as expensive in a decade. And again, what does this mean to someone who has diabetes? Actually, it was about $6,000 to cover your diabetes in 2003, 12,000 in 2012, 19,000 in 2016. It became to the public attention. There was a lot of press around it. One of the major manufacturers, remember I mentioned Alex Azar, who implemented Medicare Part D as a former CEO of Lilly. Lilly, one of the major manufacturers, was getting shamed. What did they do? Oh, no worries. We're going to authorize a generic of the same brand of our Humalog and our Lantus insulins. But they said they would charge half the price, but still use the brand name. with the insurers through their pharmacy benefit managers. So essentially, there one end of a conveyor belt that Lilly was making an insulin would say generic, the other end would say Humalog. The pharmacy benefit managers would buy all of those agents and give a rebate back to Lilly to put them on their formulary. They could do that because there were competitors. And Sanofi made similar agents, Novo Nordisk. The entire industry was raising the rates and keeping the rates high in lockstep. That would be otherwise known as price fixing or anti-competitive actions in any other industry. And here's a cartoon. This person's complaining about the price of insulin. Man, it's really getting ridiculous, says the John P. Public. It's costing me $240 a bottle to pay for insulin. And here's a lobbyist saying, you think that's expensive? It's cost me $26 million to lobby against drug reform. Anyhow, ultimately, in 2022, Congress did, again, that same relatively less conservative Congress put a cap on the cost of insulin with the Inflation Reduction Act. And the state of California, likewise, was threatening to actually manufacture their own insulin. So the state of California has a large enough economy, it could set up, again, they were not complicated processes any longer. They were threatening the manufacturers, we're going to make our own insulin if you don't lower the cost. So in response to the Inflation Reduction Act and other threats, all of those companies, Lilly, Sanofi, they all lowered their price to $35 a month. It's pretty remarkable. What else did the Inflation Reduction Act of just 3 years ago do? Well, we talked about capping insurance, capping insulin, which started actually the year later that year in 2023. And the other major impact, we may have heard from Dr. Malik, was it required drug makers to start to negotiate with Medicare. Negotiation with Medicare would not happen until 2026, and it was only for selected high-cost drugs in Medicare. There are a few other things, perhaps less important, required the drug makers to pay rebates back to the government, Centers for Medicare Services, if their prices exceeded inflation. It reduced some Part D expenses and had some income-based subsidies for folks on Part D. But essentially, its most dramatic effects was to reverse the legislation of 2003 that prevented Medicare from negotiating for the cost of drugs. Most folks who take drugs, of course, are over 65. The majority of drug costs are on an older population. So that does have a significant impact on expenditures on the national level. I think we're going to discuss this further, so I'm not going to get into too great a detail, unless you want me to, on the Inflation Reduction Act and negotiation processes. I think we'll have some future talks when we get to pharmaceutical industry. So yeah, and here we are again. And a lot of stuff, Medicaid particularly is on the cutting blocks. We are going to see a lot more on and that's a big if, this legislation passes, a lot of your patients are going to lose their health insurance. I'm going to see a lot more people in the free clinic where I work, which is not a great solution to these issues. You're going to see more deaths and and I see it, and we see it, on a daily basis. People die because they don't have health insurance, and suffer a catastrophe. So, unfortunately, this is some stuff that we might be seeing. Okay, tried to keep it short today. You've had a long morning. That's sort of some history. And what do you think? Questions? Observations? Yeah, Ariana. Yeah.
Well, I was just thinking about the Inflation Reduction Act and how it lowered insulin prices so dramatically. Like it's remarkable, but so like I guess I'm just confused how the drug companies like justified such high prices before that act. And I was also thinking about like a family friend of my family's who has type 1 diabetes. He's only in his like early 20s and he went over to Italy
Hmm.
and he stocked up
Yeah.
on insulin
Yeah.
because it was so cheap. And it just also like that connected to the Inflation Reduction Act. I'm just confused as to why there were such high prices to begin with.
I don't think you're confused. I think you are perhaps amazed would be a better answer. The thing that may help with your confusion, until the Inflation Reduction Act, um, this country was operating on the conception that the free market will reduce prices, less government interference, the better. People will shop around for their insulins, and that will, just like the price of refrigerators or cars or whatnot, or pens or whatever it is, that's going to reduce prices. It's not was, that is the prevalent theory that many politicians make their bids on. In reality, why is that insulin affordable in Italy and it's not here? It's because every other nation on earth, other than the United States, if they are a wealthy industrialized nation and they have health insurance, which all of them do if they're wealthy, negotiate with the drug manufacturers and say, no, my citizens are not going to pay $199 for Humulin. That's absurd. There's three manufacturers. Let's see, Lilly, Sanofi, Novo Nordisk. I want to know which of your products are going to be least expensive, so I'm going to negotiate on behalf of 100 million residents. Okay? And take it or leave it. Remember, we're talking about monopsonies. If you've got one player, namely the government, protecting the interests of their populace, no, we're not going to pay that. We're going to pay this. Take it or leave it. We've got 100 million people you're going to make some money on. You want that population to take care of? You're going to pay, this is what you're going to pay. Does that make sense? In the US, there was no such legislation. Sanofi, and again, there is antitrust legislation. Sherman Antitrust Act from the 1800s supposedly prevents collusion among manufacturers of a product. We saw how all of those drug manufacturers were in link, raising the prices almost identically. I mean, that may not have been happening in back rooms. They just saw what each other was charging. But still, there was no regulation. And remember, the thing that also shouldn't confuse you, these are for-profit companies. By law, for-profit companies, their mission statement and actually their legal obligation is to maximize return for their shareholders if they're traded on Wall Street, right? That's so sort of legally that they have an element of maximizing their profit. Is that compatible with healthcare? Hence the confusion. Shouldn't be an element of confusion. It's nuts that more Americans don't know this and aren't really grappling with this, understanding this. Hence, here we are. Um, Therese, you have your hand up. Yeah.
I think in like the last year of the Biden-Harris administration, they announced a plan to lower prescription drug prices for like 10 drugs or something along those lines.
Yeah.
I was wondering, was that a continuation of the Inflation Reduction Act or was that a separate plan? And if it was a separate plan, like is it still going to, do you think it's likely to
Mm.
still be implemented in our current administration?
Two very good questions. And I didn't go into detail today because I wasn't sure how sore your butts are from this morning. I think we're going to have separate. Sorry, Marvin, wasn't an implication. But we're going to, I think, have separate presentations on this when we get to pharmaceuticals, and we'll get into this in more detail. But short answers. Initially, there were 15 drugs that would be selected per year in a rolling fashion. Again, ideally the highest cost drugs and the drugs with the most impact on patients' care. So initially, and by the way, the other thing is when legislation passes, To get it passed by the opposite party, you've got to give them some perks. Remember, this was passed in 2022. Doesn't really take place till next year, 2026. I mean, this is nuts. But just as we saw with insulin, it does start to have some effects as things are being threatened, perhaps. But anyhow, so for instance, apixaban, which is Eliquis, was selected as one of the drugs to lower the cost on. Some of the other age they selected based on prevalence and cost, but it's rolling out every year. Okay, there are problems. And the pharmaceutical industry is very smart. They have very good ways to counter this. Your second question is it going to continue? Uh, Keep your seatbelts on. We ain't going to know what's going to happen in this next administration. Believe me, they're trying to counter that, or throw in changes in the law in terms of how long a drug is out on patent, for instance. The other thing is that, again, we'll get into the details, but those selected drugs had to be um, uh, on the market for not less than 7 years. That is, the pharmaceutical industry had 7 years to recoup profit. Okay. And so you couldn't put that negotiation for a product that was introduced more. That's not the case in other countries. Again, it's these pressures, legislative legalized bribery by the pharmaceutical industry and others with lobbyists that affect the sausages that are getting ground out from Congress. But I hope was that and we will get into this in more detail because these are major issues. But remember, in terms of thinking about costs and our that 18% of our 19, 20% of our gross domestic product going to healthcare costs, actually hospital costs have gone up higher than pharmaceutical costs. So bearing some of these things in mind, there are many other issues at play here. This is a major one, and it hurts people's pocketbook directly. Yeah, good questions. Um, I mean, so it's a wacky world we're living in. And part of our goal is to help educate the people that you work with, your fellow doctors, your fellow students. Many of the doctors you work with do not have insight into this. It's deliberately complex to keep things that way. Other thoughts? Yeah. So, um, we've been not just only been an hour. It's not been too terrible. Um, but I think in going forward, a lot of the history that I've been presenting is relevant to what's happening in Congress as we speak. How Medicaid got implemented, the fact that health insurance was advocated for by one group, essentially the elderly, whereas another group, which is folks with lower income, did not have advocates. They had, public um, uh, imperative to cover their care to some extent, but they were always not valued as much politically as well as economically. And so we are seeing Medicaid restrictions being re-implemented because folks are just not worthy if they're on Medicaid. They should be able to afford something, even though they may not. And again, in your experiences dealing with patients, you'll see how people's incomes are affected by life events. Um, uh, Again, there's certain streams that are more recent. Um, in the 1950s to 1980, I would say, nonprofit forces dominated in healthcare. Blue Cross Blue Shield was a major insurer. Hospitals were nonprofits. There was no such thing as Tenant or Hospital Corporation of America. There was no such thing as corporatization of insurance across state lines as we see today, or at the levels that we see today. What we've seen with essentially financialization and corporatization of healthcare, I did not touch, by the way, on the financialization of health practices. I didn't talk about private equity. I think we'll have future discussions on that. Basically, doctors, the other trend was most doctors were self-employed. They were not employed by large health systems. And that has changed. They're now employed by these large, powerful, when I say health systems, I mean hospital systems. We don't have a system of healthcare in the United States, but we have health systems across areas that sort of substitute for that. The majority of physicians are either employed by them or by actually now United Healthcare or insurance companies. Again, this is due to lack of regulation. Uh, I may have mentioned in passing, United Healthcare owns primary care practices and physician practices. Are you guys aware of this? Private equity got into purchasing initially anesthesia practices or dermatology practices, traded on Wall Street. Okay. And so basically, you can imagine if there's some pressures on doctors as gatekeepers to restrict care, if you're hired by United Healthcare, Optum, you're going to have a whole set of other pressures on you in terms of how you deliver healthcare. So this is a really crazy world we're in today. And I don't know whether revolution is in the cards or how we're going to get from point A to point B, but education about what we're contending with is part of it. Does that make sense? So hopefully this history is of some benefit. All right. I think you guys know who you're meeting with later today. I think there's a 1 o'clock session you'll be having as well. Any other observations before we move on to the day?
There's just a 1 o'clock, right? There isn't one after that.
As far
Okay.
as I know, it's just a 1
Okay.
o'clock. I've been sort of tied up with a variety of things this past week or so. Marvin, are you on the line? I see Marvin's just attached, but I'm not sure he's able to hear us. So, but as far as I know, the next meeting's at 1 o'clock, and I think you'll be talking with them. Who's going to introduce the speaker? Do you guys know?
I am.
Okay, great. And I think Betty may be there as well. So other thoughts just in terms of as the week is coming to a close? You've had excellent questions. There's a lot of stuff to learn. And we're going to get into the weeds of pharmaceuticals, maybe into some of the weeds of um, insurance functioning, and certainly the question about insulin in Italy. We're going to certainly have lots of comparisons with other nations and analysis of how one looks at a health system, how it serves its populace. So that'll be coming up in weeks to come as well. Yes, Ariana.
I guess this is more of a general question, but because a lot of this is very new to me and I'm trying to keep it all straight, but I am cognizant of the fact I will be going back to school in 2 weeks and learning a lot more medicine. Like, how would you suggest, like, us and myself, like, keeping all of this
Mm-hmm.
in my head so I can continue to like use this knowledge and educate my fellow classmates as I, pour more into my brain this next year?
Well, a couple things is join PNHP. If you do, how many of you have a snap chapter where you are going to school? So, so if you don't have a snap chapter and you want to get engaged and make a change for the lives of your patients as well as your own, let's get one started. It's a flippant answer, I get it, but that's one way basically to get information in an ongoing way. You're not health policy scholars. You're physicians in training. I think it's hard to learn basic science, preclinical sciences, when and health policy simultaneously, right now, what fits into your training is what you're going to be doing. So if you're learning about, streptococcus versus staph infection and the cellulitis, it's clearly relevant. It's right there. You're going to be learning this because you're going to have to select the antibiotic to treat that cellulitis. Okay? What's less relevant is, well, this patient has Medicare and their Medicare Advantage plan is not going to cover the test I want to order because you're not there yet, if that makes sense. Or this patient's is not coming in to get that procedure I wanted to get because it's not covered by their deductible. I mean, they're sort of one step removed, if that makes sense. It becomes a lot more relevant when you start seeing patients on a person by person basis. From a societal basis or sort of a health policy issue. So it's a great question. As you plunge back into your studies, I think interest groups, by the way, I don't know how many of you have electives in your second year. Oftentimes there are electives. I don't, second year is going to be challenging, particularly if you're doing other, extracurricular stuff. Later in medical school, you have more time to do electives. A lot of folks will take sort of health, society, and the physician electives that will be part of when you're doing some of your training or a month or so in your training. Some of your professors are probably offering those programs. At Rowan, I know there's a lot of interest in providing this in an ongoing way. Um, I think so. So it's a challenge. You're learning a lot, and this is one element of it. I'm not sure this is a great answer, and it's a good answer, a good question also to ask Betty, who does a lot of this. And the students I work with, and I am working with first and second year students, as well as later students and residents in training, this always comes up. By the way, once you guys are in the clinics, which won't be that long from now, every school's a little different, but you will see how this conversation will come up naturally when you're seeing an actual patient and having to deal with actual payment for an actual care. So that will help with underpinning a lot of what we're talking about. Um, I think now is the time I think you guys are super to be here to learn about this, to have some basic understanding. And then I think it's going to be reinforced naturally in your training. In the next 6 months, if you're just doing basic sciences, I think you'll have to reach out a little bit to maintain your knowledge on this. The other thing is if get a source of news. And I mean, I don't watch much TV anymore either. You guys never watch TV. But your social media is probably reporting what's happening in Congress. A lot of stuff may be a little, yeah, and I have to say it's so far removed from the history we've been talking about. All you're hearing about is Medicaid repeal or Medicaid, barriers of this, that, and SNAP and this, that, and the other thing. But it's understanding that they're trying to repeal the ACA with a lot of the reforms that are being implemented. I think trying to sort of discern what's going on actively as we speak may be valuable too. Long-winded answer. The longer the answer, probably the less confident the giver of the answer is, but yeah,
I
good
guess
question.
this is, or sorry.
Yeah, no, not at all, please.
I know you're saying that they're trying to repeal the ACA and then like they are actively like that's not even up for debate. But what are like the significant parts left of the ACA? Because I know you had the slide where conservatives already have like pretty
Yeah,
substantially attacked it. What
you
is
are
like
right.
the if there's like three main things that
Yeah, I'd
I know
say
like
one main
26.
one main thing, expansion of Medicaid above. So when Medicaid was passed in 1965, it was based on income, right? Poverty level. What Obamacare, the ACA did was it expanded that poverty level. You're eligible for Medicaid if you're not quite as poor. Does that make sense? That's number one. So its major implications are what you're seeing to get around that is to put additional barriers state by state with work requirements or other, if you don't have children and you're a certain age or this, that, and the, you're going to see all sorts of other things which will have impact. Does that make sense? There is a population of folks also these premium subsidies. That's not a trivial number of people either. These are folks up to 400% of poverty level where that if they get Obamacare from one of their marketplaces, the premiums are affordable for those people because the insurance is getting paid by the government. Okay? They're trying to eliminate that. I think what you're also going to see is the availability once again in wide scale. And I have to say, I used to see this. Patients would have insurance that was literally worth how much the paper it was printed on was worth. They'd have these catastrophic insurances. They come in to see me. They've had serious medical problems. No coverage for their hospitalizations or for their other services. And you're going to basically, buyer beware is the theory of the conservatives, which is why to allow such plans. Well, buyers are not aware. So you're going to see implementation of that again. These are going to be efforts to be made that will be made again. So perhaps those three things to keep an eye out for. And repeal of the Inflation Reduction Act and allowing pharmaceutical companies to, charge what they will. But I think that's an important question. I don't know if we have a talk currently designed around the Reconciliation Act that's in Congress. I don't think we do. And stay tuned, it may not come to pass, but I think PNHP will probably come up with some statements on this as well. And you can certainly, Kaiser, and to answer Ariana's question, some important sources of information is Kaiser Family Foundation. It is a terrific, it summarizes things in an understandable way if you have questions about something. Commonwealth Foundation is terrific for international comparators. But anyhow, so did I answer your question, Zachary? Does that work?
Yeah, I just wanted things to point out when people say like, why is the ACA important? Or yeah. So yes.
And I was trying to underline that all of these, remember I mentioned the public option, quote unquote, was part of the ACA. It got shut down. I actually met with Valerie Jarrett, who is the right hand, I think she's passed on, with the right hand person of Obama when they were going through the primaries in New Hampshire. It was very clear from the outset that as much as maybe they would love to see Medicare for all, they knew it was not going to pass in 2012. And as soon as I brought up the idea of Medicare for all, she said, this is not going to happen in this Congress. The ACA, its importance is really just one of numerous parallel programs to try to fill the gaps due to the absence of an actual medical system, a comprehensive medical system in the United States. So we've got, as we talked about, the Indian Health Service, you've got the VA system, you've got CHIP, you've got TRICARE, you've got ACA, and you've got Medicare, and you've got Medicaid. They've all these parallel systems, all of which got implemented at some point in time in history in the past 50 years to fill a gap of the uninsured in absence of having a comprehensive Medicare for all, or I don't care, Medicaid for all, whatever you want to do, some kind of comprehensive program. So I understand and I don't know what's happening with the ACA. I think that it has held its ground in part with some of the rules set in during COVID to make sure people didn't lose their insurance. But I think that it is expensive. A lot of people, how many of you have, out of curiosity, have a silver, bronze, platinum plan or something like that? Usually students will. Now you may get covered with your folks, you may get covered for your other programs, but a lot of young people, but less so now than probably 10 years ago, Zachary. So it's filling the gap primarily, I think, with the expansion of Medicaid. Some folks still get it, but it's costly. Yeah. All right. Well, we have worked together to try to understand an incomprehensible system for another hour. And hopefully in your lifetimes, we will see some major life changes.